Well, this is Claudia Benton, and she has agreed to be here to work with me this morning or evening or afternoon, wherever you are. And Claudia, so much welcome, and thank
Thank
you
you.
very much for
Sure, my
coming.
pleasure.
And as we've been preparing ourselves here, Claudia and I have gone through some description of what's been going on for her. Her presenting issue that she uh, listed herself for today were problematical knees and a little bit of meniscus damage, a little bit of collateral ligament stretching, and she's discovering that she's a great hiker, and she's discovering if she tries to keep up with her husband or if she pushes herself too far, uh, too fast, those knees really kick up on her, and various activities through the day will cause that same arrival of limiting discomfort and compensation patterns. So, Claudia, I'll just ask you to reiterate with me and for those listening what's been going on in your system and knee. And she brought a lovely MRI report that gave me a pretty good structural picture of what's going on in there.
So, my husband and I have done a lot of hiking, and about 2 years ago, we hiked the Tour de Mont Blanc in through Switzerland, Italy, and France around Mont Blanc. It was 110 miles, 40,000 feet of elevation gain and elevation loss. Prior to doing that, my left knee had been a little bit tweaky, and I'd gone to PT and strengthened it, and I did great. My knees were perfect, and I came home from the TMB. And about a month later, I was going on a super short, really little walk with a friend of mine. And she said to me in the walk, "How are your knees feeling?" I said, "They feel great." And I came home. My husband was lying down on the bed. I hopped on the bed, talked to him for a minute, got off the bed, and must have twisted. And I think at that point, I tore my meniscus. So that was almost 2 years ago. And I went to the orthopedist, did an x-ray. He said, x-ray showed only any bone damage. There was none. And I thought, well, I already know the physical therapy exercises. I'll do that. And it, sort of got better, but was never perfect. And around Christmas this year, something happened again, and it was just agony. And I was in my chair with ice for several days. Went back to see him and had the MRI done and found that I had had a tear in my meniscus, a huge cyst across the front of my knee, a cyst behind my knee, and 3 places of bone on bone arthritis. So he said he could do laparoscopic surgery. And my old physician, dear friend, said, absolutely no, do not do that. Bad idea. So I asked to go to physical therapy again, which I've been doing for the past several weeks. And I think it's sort of helped. And in the meantime, Saraswati set me up with Deane. So I've been looking forward to this as well. Throughout this, I've continued to go to yoga very regular times a week, often a third time during the week. And I've continued to do some hiking, but not anywhere to the extent that I had been. So about a 3 to 4 mile hike is about what I can do, with the downhill being much more challenging than the rest of it. So that's sort of my knee in a nutshell.
Yes, yeah, and the what you're noticing with the added stress going downhill is universally common. I find the same thing because when we're going uphill, you're you're gradually weighting that knee and pushing up. Going downhill, you're coming down on it, and the muscles, instead of working like this as you're walking uphill, the muscles have to meet that impact that goes through the thigh and the hamstrings coming downhill. So it's muscularly and soft tissue wise, it's going downhill is always more problematical. And I also noticed on her MRI which links to the thought I just expressed, was the examiner was not completely thrilled with the alignment of her patella, that it was not tracking straight in its groove in the front of the knee. So there's a little muscular imbalance above that is kind of pulling that patella slightly off track. And those cysts have developed as a functional response of the body to a cyst is a little bursa-like cushion. You know, it's a connective tissue sac filled with viscous fluid. And that's the body throwing in a little extra padding, which in the short term is a defensive response to the added stress on this or that particular point. But in the long run, that bursa, if it persists, can become a prosthesis, as it were. And so the body aligns around that cyst rather than the healthy joint aligning around the gravitational action going through the body. And as we were talking, she also brought up the fact that she has many years worked as a nurse, and partly psychiatric and partly injury management and recovery. Am I correct?
Yeah, the psychiatric was before I was a nurse, and I've been a wound ostomy nurse for many years.
Ostomy nurse.
Yeah.
So that is an occupation that entails much leaning over beds and much very poor ergonomics in that posture of trying to turn patients in their bed, and a lot of stoop stress going through that thoracic column. And what emerged as we were chatting was kind of a chronic, you know, I'm going to have you turn sideways for just a moment here, Claudia. Yeah. And see this little forward carriage of her head and this little curve forward of her upper thoracics. And that's giving her a lot of symptomology through the musculature here, because as her weight goes forward, to keep from falling forward, all of these posterior muscles from neck all the way down to the heel have to go into a steady contracture so you maintain your balance. That throws a lot of weight off your heel onto the ball of your foot, and those back muscles are in a continual state of corrective contraction to control balance. And I have the notion that this carriage of all this upper weight of her upper thorax and this shoulder girdle jacket of muscles that have become arranged in this fashion, instead of dropping nice and wide and straight down the back so those back muscles can relax, has had some real impact on the knee situation, because that slight tilt forward, that contracture of the back of the legs, and as the back of the legs take up the tensegrity tension to keep you from falling forward, that means the quadriceps are dropped in tone and go somewhat offline and can begin to weaken, which is why walking downhill perhaps has become more and more challenging. So I thought I was going to be working pretty exclusively on these today, but as we open up this picture with Claudia, what I've realized is we're going to do some rearranging of muscle lengths and synergistic arrangement of the weight of this shoulder girdle jacket, which all the way from occiput through front sternum all the way down to the pelvis is the synergistic musculature that controls all this shoulder weight bearing chronic positioning. So we're going to bounce back and forth between shoulders and feet and knees and see what we can get to emerge in our time together. So thank you, Claudia. You can turn back so they can see your face for a moment. Because one of the things I want to start with is just taking a look at you walking back and forth over towards that orchid over
Okay.
there and back. And as you, let me make sure I'm getting a good camera.